The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our November 13th Safe and Calm webinar. This morning we only have a few very brief updates, but before we get started, we want to take a minute and note that our webinars, as you might be aware, are developed very rapidly in response to what we see coming from either the state or the federal authorities in terms of both regulations, requirements, and whatever issues might be arising. So while caseload continues to rise, and we know that our members and other providers are more and more stressed all the time, we also see that, thankfully, to some degree, we see fewer changes and updates from the state and the federal government. But we also have to note that those regulations in place are still very burdensome, and they're often confusing, and they create quite a challenge sometimes. But as we're looking down the road, we anticipate that we may not have enough new information to continue to sustain 2 webinars per week for much longer. At this point, we often think that we have absolutely nothing to report on Thursday morning, but then the state seems to come up with more material, and then here we are. So because of all that, we're asking everyone to pay close attention to your email in the future. We may have to cancel the webinar at the last minute, and we will wait probably until the last minute to ensure that there is no updated state or federal guidance that we might want to talk about. We certainly do not want to take up any time when there's nothing really new or essential in terms of topics. We're also aware that with the number of requirements and the confusing language that is in some of these regulations, and we're going to talk about some of that today in particular, that there are a lot of questions and confusion and sometimes conflicting guidance out there. So if we do start to decrease the frequency of our webinars, we do encourage everyone to continue to email either Dalton or myself or the Safe and Calm email address for any questions that you might have. We have worked hard to provide very timely responses to those questions because we all know that everyone out there is working very hard to keep things under control. So our agenda this morning includes just a few brief topics. Dalton will start us off with a very, very short update on provider relief grants. We will take a moment to look at the Michigan numbers since they seem to be changing rapidly. And we will follow that with a few updates from the state. So at this point, we'll turn the presentation over to Dalton, our Director for Public Policy.
Good morning, everyone. As Deanna said, I have just some brief follow-up regarding the Provider Relief Fund Phase 3 applications. HHS has reached out to the associations and let everyone know that they're struggling to confirm the data submitted by some providers. They gave us a deadline, an absolute drop-dead deadline of this afternoon at 5 to get all this information in. HHS actually sent out a list to Leading Age National, who then distributed that list to the state associations to follow up on. I've been following up on the Michigan list, and if you have not heard from me directly, whether that be a phone call or an email, you do not need to worry about it. You're all set here. But if you have heard from me, I believe I have information submitted or updated information from every single member who is on that list. But if you do have any more information you'd like to share, please be sure to get that to me before about 4 o'clock today, because I have to get it upstream to HHS by 5. So please feel free to reach out to me if you have any more information. And if you have not heard from me, you're all set.
All right, thank you very much for that, Dalton. Before we get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo during our annual conference. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. At this moment, we don't have any questions, so we can move on.
Okay, so one of the reasons that we do the situation update is to take a moment and reflect basically on the overall risk for our member providers who are directly affected by the amount of community transmission. So recently we've tended to focus more on the actual Michigan data as caseloads have increased. And this morning we also want to take a minute to acknowledge the situation that we seem to be headed for. Yesterday, a group of hospital CEOs issued statements again that unless we start managing the outbreak better, hospitals will be in crisis soon. And they are also being challenged right now in terms of their overall bed capacity. And they're considering, again, stopping all elective procedures, and some have actually already done that. They're also calling for stricter rules regarding safety precautions, and they're particularly calling out that it might not be enough to simply wear masks when going out, but those personal social gatherings in our homes are problematic. That sharing food is difficult because masks are not worn during that time, and sometimes they're not worn at all during these social gatherings. So with the holiday season coming, the situation is going to be challenging for members as well as families. They will want to visit their loved ones, we know that, and we're going to talk a little bit more about that later in the presentation. So moving on to the actual numbers for today, we have updated the 7-day rolling average caseload graph with data as reported through 11/11. And I kind of put arrows where it was as reported on 11/9, which was in the webinar on Wednesday. There's always a little lag time. And on 11/4, the previous week. And you can see that we've had another significant increase in just these 2 past short days. As the governor said yesterday, the numbers are going straight up. And although we've had kind of a really much improved death rate recently, you can see also that those numbers are increasing rapidly as well. So with that hard news behind us, we will move to a brief discussion of MDHHS and Bureau updates that have occurred across the past 2 days. So first we're going to start with the CRC update. Yesterday during a provider call, the department announced that they now have 17 total applications for CRCs. And at this point, 2 have been approved, the Middle Lodge of Frankenmuth and the Lodge of Taylor. They also noted during that call that there are 4 more reviews that are fairly far along in the process. To date, 2 providers have been denied. And the state has not announced the names of any of those other facilities other than the 2 that have been approved. There are now 2 applications for Region 7, which was one of the regions before that had no applications. Region 7 includes 3 counties around the Jackson area. But they also note that, and this is what they stated yesterday on the conference call, there are still no applications for Region 1, 5, and 8. So that's a little confusing to me, at least. You can turn the slide, please, Blake. Because one of the problems with communications with the state over the regions is that they use different regions for different purposes. The MERC regions that they use to monitor the transmission rate, those are the 8 regions that are on the MySafe Start map. They're not the same as the Healthcare Coalition areas. But at any rate, according to the MySafe Start regions, the department says we have no CRC applications in the upper, in the Lansing region, which is Region 5, which is in the center of the state there, and in Region 1, which is a lot of the counties in southeast Michigan. But that is where the Lodge of Taylor is. So we're not understanding that. We have a question out to the department to confirm where their needs are and where the applications are, so that we have a sense of where we can look for resources. On Wednesday, we talked about the updated financial guidance for testing that the department put out. At the least, it was confusing at that time. It was confusing to me, at least, and actually it seemed a little contradictory as well. And since that time, I think we talked to the department a total of 4 times about this. Apparently, they said that there was an error in the language. The language in front of you right now is the corrected version from that document. And I still find it somewhat confusing. And I finally figured out where I think the grammatical errors are here. So we're going to review this slide, the content on this slide, piece by piece, and identify what the department says they really mean here. Again, we had to talk to them several times to get this straight. So in general, and this is the piece that seemed conflicting in the beginning, but this is the overriding rule. MDHHS is going to pay for specimen collection for staff, residents, and visitors whenever the facility collects the specimen. Remember, that's the overall rule, and they're going to continue to pay their $22.07, which is 86 or so percent of the Medicare fee screen for that. That has not changed. As usual, the department's going to pay for tests that are not covered by insurance, and that has not changed either. So that bullet point here is not new and has not changed. This next part says that nursing facilities will not be eligible for payment for laboratory-related costs after receiving antigen tests. And this is the corrected language. And even though the state left this language in here, they don't really mean that you cannot bill for any necessary PCR testing if you have received and are using point-of-care tests as well. We pointed out to the department that that didn't make any sense to only pay for POC testing if you've gotten tests, because confirmatory PCR testing would be needed, and there might be a lot of other situations where there's testing needed. And in their response, they said that it wasn't their intention not to pay for all the tests. What it seems to be mostly about is that the state is concerned about double billing and wants to make sure that it's only paying for the tests that are actually appropriately conducted. So as this is written, it doesn't really apply, in at least the way I read it. So they will continue to pay for both point of care and PCR tests as you use them. They just don't want to be double billed. And lastly, the last bullet here is the piece that caused us the most confusion. And I think it's because of the way they worded it. After the first statement, which says they're going to reimburse for specimen collections for just about everybody, they said that a nursing home will only be eligible for specimen collection when antigen tests are used. That's not what they mean here. They mean that whenever an antigen test is used and that has been provided by the state, they're only going to pay for the specimen collection. They're not going to pay for the test because they've only provided it, which makes perfect sense. So the guidance still continues to be confusing, but I think that we have clarity. And in the next slide, Blake, you can move it forward. The next slide identifies pretty much verbatim, I added the word PCR there, I think, what the state told us in terms of clarifying all of that. They will pay for PCR testing whenever it is used to meet resident and staff needs. They did allude to an error in the first document. I'm not even sure where that error was. I've not found it, but I still do find that language confusing. But they confirmed that they meant that if a facility is using state-distributed point-of-care tests, reimbursement will be limited to paying for the collection in that instance. And they will continue to pay for PCR tests anytime needed, as I said earlier. And facilities who have point-of-care tests but have not used them, and this was a point of concern, they should go ahead and keep them in case they need them for an outbreak or for visitor testing. But if you choose not to use a point-of-care test, keep them. You can go ahead and conduct PCR tests and bill for them as well. Another ongoing issue that we have had is the distribution of announcements from MDHHS. Many of the department announcements, especially those that are related to any public health concerns, come through MyHAN. That is the Michigan Health Alert Network. We have encouraged, through the course of the pandemic, our members and providers to register to receive updates through this system, because sometimes that's the fastest and quickest way to learn what's going on. However, it's been a challenge for HFAs and AFCs. They do not have access to this system, and apparently they will not have access. The Bureau says that there are just too many HFAs and AFCs, and that would overload the system. So they have suggested that the association distribute information to all of our members when we receive it, which we do. And we continue to argue for the inclusion of HFAs and AFCs, but the department has said it is just not possible. So, any questions about content to date, and I would imagine in particular reimbursement for testing?
All right, thank you, Deanna. Before we get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. We do have a few questions. I'll just get right into those. If you took an admit that tested positive for COVID on admission to the hospital, they spent 10 days in the hospital, symptoms improved, and no fever for 24 hours before admission, would you need to put that resident on any precautions when admitted, and could you room with other residents not on a 14-day quarantine?
That's a good question. I'm not sure if this is a nursing home house surveyor would think about that. I would think as soon as they no longer meet transmission-based precautions, if they have met the criteria, I think that you could admit them as a resident without putting them in your observation unit or applying any transmission-based precautions. I'm pretty sure that there's guidance out there that says that people who have been positive or have met the criteria to discontinue precautions do not have to be placed in that observation unit, yes.
As the case counts are rising, do you feel that IL communities could insist that visitors or care providers provide COVID testing results?
I think that there is some HUD guidance about that. I would have to look for it in particular. However, I'm pretty sure that in terms of a public health requirement, you can make those decisions based on your local conditions. You might want to obtain some support from your local health department, but the transmission rates in almost every county over the state of Michigan are high enough, I think, that would support that. And I think that does clearly align with the current HUD guidance if you are a HUD type of facility. And otherwise, of course, you can make your own policies and procedures.
Once the rapid test supplies provided by MDHHS are depleted, will they reimburse for the cost of test kits subsequently purchased by the provider?
My understanding is that they are going to pay for just any about any testing supplies that are used for residents, staff, or visitors. However, if you are looking to replace some of your point of care testing supplies, you should go to the state first. And the MDHHS coronavirus resource webpage, which speaks to all of the long-term care plans that we've referenced many times on these webinars, includes the testing reimbursement request the testing assistance form, which asks the state for additional test kits. And also the state monitors whether or not you have point of care testing supplies based on the reporting that you give. So I would go to the state first to replenish your supplies, but my understanding is that they will pay for those supplies if you go to another party as well.
MIOSHA has begun issuing $7,000 day fines for non-essential workers not being protected by working remotely. Has there been any discussion regarding LTC and what is essential, non-essential, including administration? Knowing a policy is required for non-essential staff, is there any draft policy or language you would recommend?
I'm not aware of any language that identifies at this point essential and non-essential workers, especially since the executive orders have become kind of defunct. I think that I do know of some Q&As, be it for HFAs, AFCs, or nursing homes that have been distributed by the state that talks about some particular categories of persons who are essential. I'm not sure who they identify who non-essential is, or that either of those lists are completely conclusive and exclusively discuss who is essential and who is not. So if you have a particular question, please submit it to me individually, and I will relook at the MIOSHA guidance. I did look at it when it was first updated several weeks ago, and I will try to find out if there's anything particular in that guidance that they included. If my memory serves, they may have included some basic categories of persons who are essential and not essential, but I'm not 100% sure of that.
If a facility has to test twice a week and an employee is off for work part of the week, can they just test that employee once that week, or do they still need to be tested twice?
If somebody is not working in your facility, they're off for part of the time, you don't necessarily have to test them twice. You do have to screen them for symptoms whenever they return to work, and you must look at them closely during the interim period until they are tested again. Unless there's some specific reason to test them immediately, they can wait till your next scheduled testing.
Okay, give me 1 second. Does reimbursement depend on staff physically collecting the specimen as opposed to visitors collecting their own specimen and staff then processing the test?
I don't believe that there's any reason to think that the state will not reimburse for that scenario as well, especially considering if visitors are collecting their own tests, there really should be a staff person close by, obviously socially distanced, but as a precautionary member to make sure that they are collecting the specimen appropriately, and of course they have to conduct the actual test. So we've not received any guidance from the department otherwise, and I certainly would go ahead and bill for those persons.
When you say go to the state for new supplies, where exactly should we go to place an order for additional test kits?
There is in the MDHHS coronavirus resource page, which we've referenced quite a bit. And if you don't have access to it, I don't know the link and everything off the top of my head, email me directly and I will send you the link. There is a long-term care COVID plan webpage. The first item on there is testing. And when you get to that testing link, if you open it, it will have all of the forms that you need. It will tell you directly where to send the request for more test kits.
Evidently, the form for reimbursement does not include a spot for POC test kits, only the reimbursement for staff time to conduct the POC testing. Can we get guidance from MDHHS on how to claim the cost of any purchases made for test kits?
Let me review those forms. I've not looked at them recently. If you are asking for reimbursement for lab tests, that's still a possibility. If a lab is invoicing you perhaps for Medicare A PCR tests, you're still submitting invoices for that. There was an avenue for that, and I would think that there'd also be an avenue for any kinds of supplies that you get. The form, sometimes the state forms are not specific to our needs, but if indeed that isn't in the form, we'll talk to the state about it, but I will review the form.
MIOSHA just stressed again that any work that can be done remotely must be really focusing on office workers.
Oh, that's true, and that has not changed throughout the course of the pandemic. Any work that can be done from home must be done from home. I'm sitting in my dining room as we speak.
Members may want to check out the OSHA guidance at the compliance store for a national template as a resource.
Right, that's good. There are a lot of compliance store documents and policies and procedures that can help as well.
Suggestions for those weekend-only caregivers when we are in twice-weekly testing. Could we just test with a POC when they work once a week, or do we have to have them come in twice a week on testing days?
That was a question that was kind of implied earlier, and it came up in my brain with the last question about the frequency of staff testing. I don't know what the surveyors would think about that. I would think that testing more than once a week, if your staff are only in your facility once a week and you're doing a point of care testing as they come in, I would think that would be sufficient. But let's we can take that question to the state to make sure that you're not going to get cited for that. We all know how surveyors can be.
All right, it looks like that was the last question, so we can move on.
Okay. So the rest of today's presentation is really focused directly on nursing homes. However, I want to also encourage HFAs and AFCs to stay online if you are currently, because a lot of this guidance can be viewed as appropriate practice for them as well. The Bureau issued surveyor guidance first about a month or two ago, and it talked about several scenarios that we found a lot of members were being cited for, and we thought inappropriately. We had a lot of conversations with the state through that process, and they finally issued guidance that actually kind of backed off some of their citations, not many, but some of their ideas of what a deficiency would be. And now they are in the process of updating that guidance. So this is updated as of 11/10, and it's being issued to LoRa surveyors today. So because of that, we are we've been asked not to actually distribute the document until after today, which we can do next week. But we can talk a little bit about the content. So the guidance starts with a review of the regulatory language at 880 and 838. And I'm sure that most nursing homes are familiar with that. One of the reminders is that the guidance includes a clear statement that if the policies as written in your facility exceed the national standard that the nursing home is using, remember, you must reference a national standard, and most people are using standards from the CDC, that if your own policies exceed those standards, you're going to be held to those policy standards. You're going to be held to your own policy. That has been an ongoing rule, but it's also one that has particular meaning during the pandemic. So we want to remind providers of that. Okay, so there have been some slight changes to the language in this guidance. I wouldn't call the changes in this really significant to a large degree. I think that in part the changes were to ensure that the Bureau and the surveyors are in alignment with MDHHS guidance, but also there's a few nuanced changes that we'll talk about as we go forward. So they put together all these scenarios, and scenario A1 includes the response of the facility in terms of care and services for a person who is tested COVID positive. Another thing to note here before we go on is the use of the words must and should. Larry Horvath just yesterday stated that must, the word must means you absolutely have to comply or you'll be subject to a deficiency. But he also stated that the word should, in general, we take that to mean whenever we hear that in guidance that you really have to comply whenever a guide says you should do something. But in this document, he is saying that it means that it is the preferred recommendation, but not absolutely required. So you must place a COVID positive resident in a clearly marked COVID designated unit. And they use the phrase clearly marked throughout this guidance, and that is new. So apparently I think that must have been an issue in the past, that if you have any kind of designated units at all, they have to be clearly marked and identified for anyone in the vicinity. You can place these persons in either a private room or with residents who are also positive if you absolutely have to, but they must be in a COVID designated unit. Obviously, they must be isolated until they meet the criteria for transmission-based precaution discontinuance, and they should be transferred out of the area at that point. And of course, staff must use full PPE, including an N95 mask, if they're available. Scenario A2 is about persons who have signs and symptoms of COVID, but have not definitely tested positive. And this it could include someone with symptoms who is refusing to be tested. These persons must be placed in a single room and restricted in that room. And the room should be in a clearly marked observation area whenever possible. So this is a should. It's a strong recommendation. And if not done, we would suggest that you have some documentation about why you cannot do that. Because although it is not an action that's necessarily required, the facility must always show how it is mitigating risk. And that is one of the themes of this new guidance throughout it. Larry talks about mitigating risk. Again, these persons must be treated as if they were positive. And one of the things to note is that this state guidance does not allude to the fact that having a negative test will take them out of transmission-based precautions. If a person refused to test, you would have to keep them in transmission-based precautions as if they were positive and if they were symptomatic, and use the same criteria to remove it. But for persons who may have been symptomatic and had a negative test, it's always been a known CDC preference to also keep those persons as if they were positive And it seems the state is recommending that, not requiring that actually, as well. Obviously, you can transfer out of the unit, transfer the resident out of the unit when criteria are met. And of course, for these persons, the staff must use full transmission-based precautions and full PPE during care of these patients. Scenario B is about persons who are exposed to a confirmed positive while they were outside of the facility. These persons should be placed in a single room, restricted to that room, and the room should be in an observation area when possible. If you can't do that, remember to document. Observation and monitoring should take place for 14 days, and if they continue to be asymptomatic with no positive tests during that time, they can be transferred out at the end of 14 days out of that observation area. You need to ensure that persons who are in observation but never contracted the virus should be moved out of the observation area ASAP, because there are other persons in observation that are at high risk for being positive. Again, staff must treat this person as if they were COVID positive and use full transmission-based precautions. Scenario C1. These are residents who are also exposed, but they were exposed by coming in contact with a COVID positive healthcare professional. The preferred placement is in a single room, but if you had several persons who were exposed, it's possible to place them together. They do have to be restricted to their room, and the room, whenever possible, should be in a clearly marked observation area. It is likely that when you have a unit that has been exposed to a positive staff member, you might have to turn that entire unit into an observation area. But of course, if residents become positive at that point, they have to be transferred out to a COVID dedicated unit. As usual, you would observe and monitor for 14 days, and if any symptoms occur, regardless of testing, you should treat that person as positive. You can remove the person from monitoring after 14 days if no symptoms and no positive testing. And as before, and as usual, staff must use full transmission-based precautions for this situation. Scenario C2. These are residents who were exposed to a COVID positive roommate. Again, you should place them in a single room. Remember, the roommate has been moved to a dedicated unit. You should place them in a single room, or if you have to, with other exposed residents if a single room is not possible. They must be restricted to their room. The room, again, should be in a clearly marked observation area whenever possible. Again, you need to observe for 14 days, and regardless of testing, if they develop symptoms, you should treat them as positive. They can be transferred out of the observation area if they're in one after 14 days, if asymptomatic and tested negative. And again, staff must use full transmission-based precautions. Scenario D is for new admissions or readmissions from the hospital whose COVID status is unknown. These are people we're well aware of. These persons should be placed in a single room if possible and in a clearly marked observation area when possible. However, you can cohort new admissions if needed, as long as they have conditions that do not conflict in any way. And again, if you cannot place them in a marked observation area, you should really clearly document why. The state is going to expect that you're looking at mitigating risks for these, all of your residents based on the possible unknown status of these residents whenever possible. And of course, we know that all of these persons have to be cared for using full transmission-based precautions for 14 days. And only if asymptomatic and testing is negative can they be moved. The next pieces are those that were causing us the greatest trouble a few months ago. The surveyors were citing for not placing persons in full transmission-based precautions whenever anyone left the facility, and we knew that there was no CDC support for that level of isolation. So for residents who leave the facility frequently, such as for dialysis, the guidance notes the lack of CDC recommendations for this category or this situation. Excuse me. And even though the CDC has no research that says there's a definite benefit to placing these persons into precautions, because they are leaving the facility often and into treatment areas, they are at a bit higher risk. So facilities are expected to have a policy and procedure that works to mitigate that risk. And if we were to identify changes in this updated guidance in terms of general shift in thinking, we would say that it's that risk mitigation focus that the state is making here. In other words, it's okay not to put these persons in transmission-based precautions, but you have got to have something in your policies and procedures and some actions that works to mitigate the risk for this type of person. And although you don't have to isolate these persons technically, they do still recommend placing these persons in a single room and in an observation room when possible. You also have to demonstrate that you are closely monitoring them for signs and symptoms at the very least. And of course, if you have replaced them into any restricted environment, the same rules apply. They can be moved at the end of 14 days, which actually never happens if they're dialysis patients. And you can stop close monitoring at that point as well. And again, staff, in this case though, can use general infection control methods unless you've decided to restrict them further. They want facilities to consider using what they're called in the documents, specifically, all recommended PPE. Now that part's a bit confusing. We think that they mean consider using full PPE. I don't know that there is a recommended PPE for this category of person, but I think what the state's trying to say here is that they think you should use full PPE for these people. Scenario F is for those persons who go out of the building infrequently. Again, you should have a policy that acknowledges and works to mitigate the risk related to these people moving in and out. They should be closely monitored for 14 days. If you do decide to restrict, you can remove those restrictions after 14 days. And again, staff must use general infection control methods. The guidance also speaks to the PPE requirements for each of these scenarios, meaning that when possible, full transmission-based precautions would require the use of an N95 if available, or a surgical face mask if they're not available. They have to have a clean, non-sterile, long-sleeve gown, eye protection. And although it's not listed here, for some reason, of course, you need to have gloves. Obviously, you will have to at times conserve PPE, but if you do so, you should be documenting how you are conserving it and what steps you're taking to obtain any necessary supplies. The department states that the surveyor should default to your statements about difficulty obtaining PPE unless they have hard evidence otherwise, and that's written directly in this guidance. Remember that you can conserve PPE and extend its use, but only when you're serving one type of resident. You cannot conserve PPE and continue to use the same PPE when you're moving from one cohort to another. And you must ensure that gowns and other supplies and equipment are changed whenever they could be reasonably considered to be soiled. And again, remember that the major focus for this update is, although they're not citing facilities for not placing persons who are simply leaving the facility and returning into full transmission-based precautions, you must have policies and procedures that work to mitigate risk. The survey guide also reinforces the requirements for source control measures. There's nothing really new here in that respect. But you should note that they are focusing on a specific CDC webpage that speaks to the requirements for transmission-based precautions. And it might be helpful for members to review that now and again. The link, of course, is here. And lastly, they continue to discuss the needs for dementia-affected persons. They acknowledge that it might be hard to maintain infection prevention and control measures for these persons. And because of that, they're expecting a greater focus on hand hygiene, on social distancing, and perhaps more frequent or thorough, I don't know how they would judge thorough, but environmental cleaning. These should be emphasized for these units and these persons when you can ensure that they're going to keep their masks on. And again, they reference a CDC guidance for memory care. So that completes the content that's in the updated guidance to the surveyors. Remember, that's a surveyor guidance. It's meant for them. Larry yesterday suggested that you could possibly attach that guidance to your policies and procedures as perhaps a helpful addition. And then yesterday, CMS conducted a nursing home call. I'm sorry, it was Wednesday. It wasn't yesterday. They conducted a nursing home call that updated, what CMS is working on. They're currently talking about making phone contacts to facilities who have at least one COVID positive resident or who might be having trouble with supplies or testing. They have developed a short set of questions. I've heard that there's like 7 or 8 that they will be asking. And if they find an issue that they think, where they think a facility might need some help, they're going to refer you back to the state. They don't have the ability to really assist on a facility by facility basis. But if they think that if a given facility needs some help, they're going to refer it to the state. Another thing, and we kind of touched on this earlier, they're very concerned about the holidays, especially with the rising transmission rate, the possible commingling of several generations together during the holidays. And so they are planning on putting out nursing home guidance for that all very soon. So I'd be looking for that. They're also encouraging nursing homes who have not pretty much had their staff take the 3-hour CMS CDC training. They're encouraging that strongly if you've not already done that. They did note during the call that a lot of the facilities with outbreaks have not taken the training. And lastly, they are finalizing the plans for the pharmacy partnership program. They are very much looking forward to being able to distribute vaccines because those vaccines look like they might be coming sooner than perhaps we thought. So that ends the content for this morning. Are there any other questions?
All right, thank you, Deanna. We have a couple questions, so I'll just jump into those. How many days are required between 2 times a week testing?
I don't, I've always simply assumed that it would be a 3 and a 4 day test span there. You would certainly never do it more frequently than every 2 days. So in my head, when I envisioned complying with the guidance that you have to do it twice a week, that I would do it 3 days and then 4 days and then 3 days and 4 days on a routine. But there is nothing specific in guidance that says how you have to do that, as long as you are testing twice a week.
Okay, I'm just going to go back to C1 for this next question, as that's what it's about. Is scenario C1 a should or a must? If they are already in private rooms and staff wearing PPE, do they need to move to a separate quarantine observation area?
It's a should. However, The department kind of stepped back from all of their musts, but their shoulds are strong recommendations. So if you're not going to put this person in an observation unit or any kind of specific dedicated unit, you need to have a justification for that, because this person is at risk. And it goes back to that mitigation piece. When I reviewed this guidance compared to the earlier one, I think the earlier one was in response to the fact that we were complaining heavily that there was inconsistency and that some of the surveyors were citing too strongly. And to me, this second version is almost a little bit of a pushback to that. In other words, well, you don't have to do these things, but if you're not going to do them, you've got to have a good reason, and you've got to talk about the fact that this person is at higher risk than your general population. And how are you going to mitigate that risk? And you better have some policies for that. So I think that is the tone and flavor that is at least that what I'm reading through this entire guidance. You don't have to do it, but if you're not going to do it, you better have a darn good reason.
Where can we find this guidance online?
You cannot find this guidance online right now. We were not allowed to share it as is. Until after today. I believe that we can send it out to everybody on Monday because the surveyors are being trained to this today.
Okay. Has CMS changed or updated its policy that requires a state survey every time you have 3 suspected or confirmed staff COVID positives or 1 COVID positive resident?
I don't believe they've updated that. There's an awful lot of infection control surveys going on out there right now. To my knowledge, that has not changed.
All right. It appears that that is the last question. So if you do think of anything after this webinar has concluded, as always, you can shoot an email over to Dalton, Deanna, or Safe and Calm at leadingagemi.org, and we will make sure to get that question answered for you. Other than that, we do have the handouts attached if you want to grab those, but we will be sending them out as always along with the recording of this webinar. So now we would like to thank Deanna and Dalton, and we would also like to thank the 90 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. As of now, our next Safe and Calm webinar will be scheduled for this next Wednesday at 10 a.m. Eastern Standard Time, as always. And I hope everyone has a great remainder of their Friday and has an awesome weekend. Stay safe out there, and we will see you all soon. Have a great day.
Bye.